Okay, hi guys, welcome back to a new video on my channel. Thank you so much for all the love that you're showing my channel as well as my book. I would thank you all, and I would request you to please share and disseminate about my channel as well as my book. As I have a good news to share with you. Soon I'll be making a series of videos for MBBS as well as PGs in pathology on a separate platform, where you will be able to access those some of those videos for free and some of those videos for a nominal charge. And then later on I'll maybe be putting up my book for subscription on that platform, where you can, it's 188 rupees right now, and on that platform you will be able to access it as a subscription for a nominal fee less than 188. But that is something in future. And of course not the entire book will be there. Some important chapters of that book will be available for as subscription for you. However, if you want the entire book, then you have to buy it at the Ahuja Brothers website by typing in my name and then typing in Manual of Hematology in the Google search window. You'll reach the site from where you can order the book. I'm telling you this because a number of people are asking me this, how to order the book. So you just have to type my name, which is there on the screen right now, and Manual of Hematology, and you are going to get the link from where you can order. So I am putting in this topic in between our discussion of histopathology, because we have to do hematology. I have to start malignant hematology. So I will be finishing benign hematology with this topic. And after that, I please message me if I have not taken up porphyrias, because I feel I have done it. I'm not able to locate the video on my channel. Maybe it's with a different topic. So if, and I remember doing it, it's just that I can't locate the video. So message me if you feel that I have not taken porphyrias, because some of you are regular viewers, so you would know what topics I have covered, and more about my further ventures on YouTube, on online teaching platforms soon. So without much ado, this is a small topic, mostly morphology. You know 80% of it. There's only 20% of this that you do not know, which I'm just covering. So I'll be moving very quickly through this, so maybe just a 15 minutes lecture. So yeah, we will be discussing about the benign diseases of WBCs. So neutrophils, you know, there's neutrophilia, then there can be neutropenia and agranulocytosis. This is the problems in numbers. Then the morphological issues, there can be Pelger-Hue or pseudo-Pelger-Hue anomaly, Cheriak Higashi disease, chronic granulomatous disease, and MPO deficiency. CGDs, MPO deficiencies, etc. Somewhere they are a part of the immunodeficiency spectrum also. Pelger-Hue, pseudo-Pelger-Hue anomalies are a part of the dyspoetic spectrum, MDS, secondary MDS. Okay. So in neutrophilia, if there's an increased neutrophil, it can be reactive or neoplastic. Neoplastic means disorderly growth of WBCs, mostly in MPNs, sometimes in AMLs. Mostly reactive, that is in infections like bacterial, viral, etc. Medications like steroids and epinephrine, lithium, these increase polymorphs. Solid tumors cause a reactive change. Inflammation, tumor necrosis, emotional stimuli, metabolic disorders, asplenia. These are some causes of neutrophilia. Neutropenia, either there is, you have to, this is a flow chart where you have to guess whether it is congenital or acquired. If it is acquired, then you look for the underlying disease. If there's a, whether there's an immune response like a drug induced idiopathic, if there's no immune response, if there's a leukemia, metastasis, some infections cause neutrophil suppression, okay, and splenic sequestration. If it is congenital, then look for phenotype, abnormal or normal. If it is normal and there are repeated infections, see, familial benign neutropenia and chronic benign neutropenia if there are no infections and if the phenotype is normal. It is familial, normal phenotype, no repeated infections. It is chronic benign neutropenia. If repeated infections present, Costman disease, reticular dysgenesis, TNB, so the immunodeficiency spectrum basically. And if the phenotype is abnormal, then Sherman-Diamond syndrome, cartilage hair syndrome, Fanconi's, keratosis congenita, etc. Okay. So again, neutrophilia, some more causes: bacterial infections, burns, toxins, drugs, malignancies, and chronic dermatosis, hepatic necrosis. Acquired neutropenia, again, drug induced, benign, familial, it's not congenital even if it has the word familial in it. Autoimmune, metabolic diseases. And one of the important things that you have to do to differentiate from CML is a LAP score. And it's an enzyme which indicates the stains the granules of the neutrophil and indicates normal functioning. So if it is increased or normal, it is fine. If it is decreased, it is CML. So here you see pin's nest. This is a thin thread of chromosome which is attaching these two lobes, just like a pin's nest of a thin glass. There was a glass actually which the Britishers wore, which was something like this. No handles, just this and this used to sit on the nose. So this is known as pin's nest. Again, seen in dysplastic syndromes. Then see, this is a pelgahue or a pseudo pelgahue, a metamylo, a band form maybe this. Now you see this is the entire spectrum of dyspoetic polymorphs where the lobes are not complete. So this is a very classical pelgahue. Pseudo pelgahue in CML, in secondary MDS, etc. See, this is a dyspoetic eosinophil. And this is a nuclear remnant in the cytoplasm of a probably a polymorph. Okay, this is not a Dole body. I'll show you what it is later on. So this is just a nuclear remnant. It's more like an inclusion. Fine. So, and again, a pelgahue anomaly. So this is an entire spectrum of dyspoesis and polymorphs. So here is the NAP score. See, nicely staying in neutrophils. If this decreases, then it points towards a CML. This is leukemoid reaction where you see coarse granules, polymorphs, myelocytes, etc. And you use this scoring to differentiate between CML and leukemoid reaction. Apart from that, the cutoff of 1 lakh cells is there. Agranulocytosis, absence of polymorphs. Maturation arrest can be there where you can see myelo, metamyelo. Sorry, myelo but no metamyelo and band form. That can be there in dyspoesis. That can be there in stress. That can be there due to drugs. That is there in infection. That can be there in chemomalo. Fine. And there are Lee cells in autoimmune. See, these are Lee cells. Fine. There's some debris in this, and then the nucleus of the polymorphs is concentric at one end, and this is pink hyaline debris or globules which it has engulfed. Okay, and again, now this picture is actually of a Chediakigashi with coarse granules in the polymorphs. See, better picture over here. And this is a Dole body. Okay, these are toxic granules. So you see the difference, coarse granules in Higashi, toxic granules of infection and Dole bodies. Again, stress and infection. These are peripheral, circular to concentric, light purplish in color. All these are like Dole bodies, these are ribosomal collections. While these two, this is enzymatic defect in the granules, and this is a reaction to the inflammation and infection. MPO again, if it is decreased, then the intracellular killing of bacteria is decreased. Again, a part of the immunodeficiency spectrum. Fine, and absence of MPO neutrophils monocyte granule just shows decreased intracellular killing. Okay, and this test is known as chemiluminescence test. Okay, here you see such dark staining granules over here, some over here, no, very light over here. This is what you have to check for the functional disability of neutrophils. Again, neutropenia, I've already shared some pics. Mostly there is maturation arrest or it can be, due to uh, some acquired or congenital deficiency. Then this is MPN, where you can see a reticulin stain and you can see the degree of fibrosis in an MPN. Okay. Lymphocytosis and penia again, then their causes, most common infection, infective mononucleosis, dengue, reactive lymphocytosis, polyclonal B cell lymphocytosis, and LGL, and large granular lymphocytes. So you see, this is an entire spectrum of activated lymphos. Basically, what I see is the chromatin, how condensed or how opened up it is. And supposing this is a plasma site or lymphocyte, look for a proper HOF, look for flames at the end, look for inclusions and crystals. If you're not there, if there's no pinkish inclusion in the cytoplasm, then mostly it is a plasma site or lymphocyte. This is a large granular lymphocyte with granules in the cytoplasm. This, however, or this over here, is a blast with a more opened up chromatin, very, very high NC ratio. Compare it with this, looks like a high NC, but the chromatin looks very normal and the cytoplasm is basophilic dense blue. Okay. And eosinophilia again, connective tissue disorders cause eosinophilia, parasitic infestations, allergies, and neoplasias. Dysbiotic eosinophil is in AML, where the eosinophil can be bilobed, multilobed, and the granules are basophilic in color. That can be post chemo in MDS and in some AMLs. Okay. Monocytosis and monocytopenia. Cytosis is more common. Again, endocarditis, bacteremia, steroids, chronic infections. Okay. Basophilia is more common, seen in mixed edema, then the IBMs, the inflammatory bowel disease, then CMNs, then viral infections, hemolytic anemias, multiple causes. However, basilophenia penia is rare, seen in pregnancy, hypothyroidism, and stress. Now, this is an important scoring on neonatal sepsis. Why I'm including this over here is because this is a part of benign WBC disorders and done mostly in pediatric setups. You have to score a smear if it comes from NICU, and you have to score it to define the degree of sepsis that the child has. So, what are the points which you have to score it on? The TLC, the ANC, total neutrophil count. Then, what is the immature neutrophil in that? That is your band, fine. And metamylose. Then, what are the immature to total neutrophil ratio? Immature to mature. Degenerative changes in neutrophil platelet count. So TLC is less than 5,000, get 1 point, but equal to 25,000 at birth, 1 point, greater than equal to 30,000 within 24 hours, 1 point, and greater than equal to 21,000 in 2 days is 1 point. PNC normal 1800 to 5400 zeros, no mature PMN seen with this kind of a range, 2 points, increase or decrease give just 1 point, not fitting into any range. Immature neutrophil greater than 600 is 1 point, 600 is 0. The ratio greater than 0.120 is increase is 1 point. Immature to mature greater than zero point 0.3, 1 point. Degenerative changes if present, 1 point. Platelet count less than 1 point, forgive 1 point. So less than equal to 2 is no unlikely. There's sepsis between 3 to 4 possible sepsis, 5 or more definite sepsis. Okay, maximum you can go is up to 8. So hence, I told you it will be a 10-15 minute lecture. It's 14 minutes now by my clock over here. So yeah, this is all about benign disease. Nothing much to cover. I just wanted to cover it so that we finish with benign hematology. This is my book I was talking about, and I've told you how you can purchase it. And from the next time when I come back with a lecture, this that will be on histopath. And now we'll be starting with malignant hematology. If you want to understand that better, then buy this book, because whatever I'm telling you, most of it and more than that is in this book. And the way I tell you my troubleshoots and lectures, all that I have incorporated in this book. So go ahead, buy that so you'll understand the malignant hematology better if you do that. So I'll see you next time with a new lecture, and that will be on histopathology.